Thank you for tuning in to Docs and Boxed. Make sure you guys like this video and subscribe to our channel so that more people can get the content that you love. Enjoy! Welcome to episode 6 of the Docs and Boxed podcast. I'm joined with a king in transplant surgery with Dr. Nadig. So can you introduce yourself with your name, job, education, just the basics?
Sure. My name is Satish Nadig. I'm the chief of the Department of Transplant Surgery at Northwestern University, and director of the Comprehensive Transplant Center. I am my education. I'm from a small town in South Carolina called Irmo, South Carolina. I did my high school there, and I went to Washington University in St. Louis for undergraduate. Then I went back to South Carolina for medical school at Medical University of South Carolina. And then I matched at Harvard for my residency. And in the middle of my residency, I did a PhD in transplant immunology at Oxford in the UK. And then went to my fellowship in adult and pediatric transplantation at the University of Michigan. And then went back full circle to South Carolina to start off my career. And after close to 10 years, I was offered the opportunity to lead the program at Northwestern, and I came here 3 years ago to lead this program.
That's great. So just like before I jump into like all of like the crazy innovations you've made in transplantation, I just want to take a minute to like appreciate how amazing just standard transplants by themselves are. Like just the idea that you can take an organ from another patient and then put it into take an organ from another person and then put it into a patient's body who needs it. That's that's kind of crazy. So like, can you explain just the science and like the surgical procedures behind just standard transplants? Because I assume it's like much more complicated than just putting an organ into somebody else's body.
It's pretty amazing, actually. And I had a mentor of mine. It's a very young field, and one of my mentors was one of the people that started or discovered a lot of the anti-rejection medications that we use. And when I was first doing my very first case with him, after I graduated medical school and started my training in Boston, we had sewn a kidney transplant in together, and it pinked up and started making urine right away. And I thought, wow, that is awesome. And he said, exactly right. Do not ever lose that sense of awe. The minute you lose that sense of awe, you need to step away from the field, because it is an amazing field. And one of the things I'll tell you is that it's not new. People that have been, no matter what culture you're a part of, the idea of tissue transfer from one creature to another is in every mythologic story.
Mm-hmm.
Whether you're looking at Greek mythology, Roman mythology, Norse mythology, Southeast Asian mythology, there's always stories of tissue transfer from one creature to another, body part transfer in some cases too. So we've always been fascinated by this idea, but it didn't come to fruition until 1954, the winter of 1954, at the Harvard hospitals, the Peter Bent Brigham Hospital, when a set of identical twins walked into the office of Dr. Joseph Murray, and one had kidney failure and the other did not.
Mm-hmm.
And he convinced his urologic colleague to take the kidney out of the healthy twin, and he transplanted the identical twin that had kidney failure. And how did he know they were identical? They didn't have any matching at the time. So he's a plastic surgeon. He took a skin graft from one, put it on the other, and it took. And that's when our field was born. The problem is every iteration after that, when they were not using identical twins, did not work, because we had to be able to suppress the immune system.
Mm-hmm.
So we went through this era between 1954 and the early 1980s, where we were racing to find anti-rejection medications that stop the immune system from blocking or from attacking the organ. So some of my mentors, Tony Monaco was my mentor, that developed some of these anti-rejection medications. Then we got to the 1980s that we were able to do that. And so we started growing the field with use of preservation solutions, trying to get these organs to be preserved so they can be transported across state lines. Mm-hmm. Then the 1990s, we just got a little bit better at the operation. We started doing it laparoscopically, minimally invasively, things like that. And then everything kind of stopped. We do the operation the same way that it was done in the 50s, 60s, 70s, 80s. It's the same anti-rejection medications used in the 1970s, and the same preservation solutions developed in the 1980s. But right now, we're really in the renaissance of transplant, and we're just on the cusp of the next era, and I like to call that the era of technology. And I'll tell you how young the field is. The Nobel laureate that did it in 1954 was one of my attendings in
Oh,
residency, and I have a picture of him. He had not operated; he was just giving talks at that time. But a picture of him when I was a third-year resident in my office with he and I. The actual congressional act that legitimized our field wasn't passed till 1984.
mm,
It's a very, very young field. So how do we do it today? The standard of care. Well, most often we're taking organs from people who have passed away, either brain dead organs or organs from people where their heart has stopped, and then we take their organs. And then we immediately flush them with preservative solutions, and we transport them across state lines. And then we take them out of the cold solution, and we implant, if it's in this setting of a kidney transplant, we implant it into the pelvis of the recipient, into the artery and vein that go down to the legs, and the urine tube it's called the ureter, gets sewn directly to the bladder. If it's a liver, so if it's a kidney, it's called heterotopic, a different place, and we leave your kidneys intact typically. If it's a liver, we call it orthotopic, same place. We take your liver out and put the new liver in, hooking the plumbing back up, the blood vessels that go to the liver and the blood vessels that drain the liver and the bile duct that drains the bile from the liver. And pancreas, we do the same way, hook the blood vessels up, and that's heterotopic in the pelvis. And so the intestine to your intestines. And lungs, we do it orthotopic. We take your lungs out, put new lungs in. Heart, orthotopic, take your heart out, put new hearts in. So we do it in a systematic way, but it's very standardized. And frankly, we've been doing it pretty much the same way for decades now, which kind of brings us to this podcast where I felt like there has to be a change, and there's got to be a paradigm shift to get us into the next era, or that era of technology.
so it's been the same way for like a few years, like you said. But
Not a few decades.
so a few decades.
Yeah.
So I've heard like you also mentioned it like a few minutes ago when you were talking, and in like another article that I read, you mentioned the same idea of like a renaissance in transplant surgery. So
Yeah.
like what are like some innovations that you might be working on in your lab? I know your website mentioned cellular therapy, nanotech, and immunology. And like what do you see coming in the next few years in that?
Yeah. Well, so the reason I say it's a renaissance of transplant is if you watch the news, you see things about transplant all the time. Pig hearts going into a human, pig kidneys going to a human. We did this awake kidney transplant. We're transplanting lung transplants for lung cancer. We were the first ones to do that at Northwestern, along with the awake program. Transplanting people across cross matches, liver and kidney. We did that for the first time here at Northwestern as well. Combining liver and lung transplants for lung cancer, again, first time here at Northwestern. So I think that we're really in this renaissance because we're doing a lot of firsts. And one of the things we're doing in our lab is trying to figure out how we can change the game. So right now, people take anti-rejection medications that go throughout their whole body to suppress the immune system from rejecting your organ. But the problem is they have a lot of side effects, and people are not dying from rejection of the organ. They're dying from the side effects of the medications. But, it's a really unique situation. The organ's out of the body for a period of time. It's just in this preservation solution. By the way, the same preservation solutions that were developed in the 1980s, as I said.
Yeah. So that was like, yeah.
Perfect opportunity, right?
Mhm.
To take these anti-rejection medications and deliver it to the organ, not the patient. But the problem is the way that these preservation solutions are set up and the way that logistics are, you can't just give it to the organ. They have to be packaged in a way and delivered directly to particular cells of the organ, which is where nanotechnology comes into play. So I just package very low doses of these anti-rejection medications, in particular nanoparticles, and deliver them to certain cell subsets in the organ before it goes into the body, with the idea that we can hopefully one day get patients off anti-rejection medication. At Northwestern, we do have a trial, many trials that look at various cellular therapies to get people off anti-rejection medication. And we have 37 patients off anti-rejection medication, more than anywhere else in the world, with some of these cellular therapies. So the times are changing, and we just, rather than watch them change, we wanted to be, part of that change. So.
Yeah. So with the cellular therapies, I'm like curious. So how would that like doing that, how would that get a patient off of the anti-rejection medication?
So if you take certain stem cells from the donor that's actually giving the organ, so in this particular scenario, it's living donors, so somebody giving up their kidney to their loved one while they're still alive, which is very we do a lot. We do about 100 a year of living donor kidneys. It's a great way for people to get off dialysis, is to get a kidney from their loved one, or sometimes even an altruistic donor, and that's somebody that doesn't have a recipient in mind. And we take stem cells from that particular individual and give them to the recipient, and that suppresses the ability for the warrior cells, the T cells in the recipient, to attack the organ. There's also a different subset of cells called regulatory T cells that regulate the immune system, and we can expand them outside of the body and put them back in as a therapy. So there's various things that we can do that get into the sophistication of immunology to sort of trick the immune system to accepting that organ.
All right, now getting into the exciting part of this, I want to talk about the awake transplant that's had like it's made the headlines in like the last few weeks.
Sure.
So first of all, like when I saw that, I was just like, where do you even get this idea? Like you have like surgery is just you put a patient under anesthesia, they're like completely like unconscious. I don't know, like not definitely not awake. But then where was this idea to have like, oh, like maybe we can keep them awake with like I think it was a spinal anesthesia shot. Yeah.
Yeah. Well, as it turns out, we do it all the time with women that give birth in
Mhm. Oh,
C-sections.
oh, that's awake. I didn't
That's
know.
awake, C-sections.
Okay.
So they're awake when they're delivering their baby through a C-section, and we've become so sophisticated with the ability to do kidney transplants very quickly. It takes about 70 to 90 minutes on average in particular patient populations, especially more straightforward patients, to do a kidney transplant. And it's very systematic and streamlined. And with the ability not to have general anesthesia, they recover much faster. And so these patients, on top of being part of the what we call the AWAKE program, which is accelerated surgery without general anesthesia and kidney transplantation, or AWAKE, part of that is being able to get out of the hospital within 24 hours. And can you imagine that we've been doing 2024 marks the 70th anniversary of transplantation? Because I told you in 1954, the very first one was done. Can you imagine we've been doing kidney transplants pretty much the same way
70 years. Yeah, that's a lot of time without change.
until now?
Yeah, that's a
And
lot.
so it's up to us to really move that needle. And we have the anesthetic technology to do it. We have the know-how from other fields that do it. And we have the ability for enhanced recovery to decrease. I mean, these patients go home without any need for opioid pain medication. They're completely pain-free. They go home within 24 hours and their kidneys are functioning great. So if you can take a what could be considered a major operation by any stretch in a transplant and make it basically an outpatient procedure, why not?
Exactly. So with the spinal anesthesia shot, like how is that different from general anesthesia? Like how does it work?
So you don't need, so in general anesthesia, you need a tube down your throat and you're put on a ventilator to help you breathe, and you're completely paralyzed during that time. And so it's invasive, put a tube down your throat, you're helping you breathe and ventilate. With spinal anesthesia, it's a shot in your spinal cord, just outside of your spinal cord, that numbs the nerves that go from waist down to numb that skin, numb that area, so that you don't feel the kidney at all.
Mhm.
And then you don't need to be placed on a ventilator. You're talking the whole time, you're awake the whole time, and certainly you can have levels of sedation to your comfort. Some people like to be awake the whole time. Some people like to be a little bit sleepy. That we can adjust the level of sedation, and they're eating right away. Their GI system recovers right away. And something that we recently did an older gentleman, and in the recovery room he was asking to go home, and that's how fast people can recover from this.
So take me through like the procedure, I guess, in the room while you were doing it. Like how awkward, like I would say awkward, how like different for you was it to be like talking to a patient while like operating on?
Well, we do lots of operations under sedation. So, for example, dialysis access procedures and things like that we'll do under sedation. So, and if you think about it, many patients have, most patients have their colonoscopies done just under sedation. So
Mhm.
it's not uncommon in various fields, just not in transplant, but it's not uncommon in various fields to have the ability to talk to the patient while you're performing a procedure on them. It's just never been done in this way in transplantation. Now, it has been done before, spinal anesthesia for kidney transplant, but not associated with this enhanced recovery and early discharge, and not with the sophistication that we've done it here with the ability to keep people off opioid medications and adjusting their immunosuppression so they can leave the next day and things like that. And so I think that it's not awkward at all. The patients love it, and if you think about a C-section, the patients that give a C-section, give birth, have the opportunity to witness giving life.
That's
But
such.
in this scenario, patients that need a kidney transplant have an opportunity to witness getting life
Mhm. Yeah,
and a second chance at life.
that's super cool. So what do you think like with the early discharge? What do you think that could mean for the future? Because I saw an article that was like, oh yeah, with that it like greatly reduced the cost of hospitalization and stuff like that. Do you see
Yeah,
any benefits with it? And do you think that it could become like sort of the norm in like a few years?
that's my hope. I think that it will decrease the amount of time you're in the hospital, decreases your infection risk, decreases cost, just overall length of stay. Your comfort is better. And if you think about if you have anything done and you can go home the same day, it just decreases the risk overall for it. And I think that we've shown the proof of principle that can be done. And I think my hope is that we're going to start doing it in a trial to compare it against the standard of care and show that it in fact is better on various metrics.
Mhm.
Yeah.
All right, moving on to the next procedure that I wanted to talk about. I think this was earlier this year with the double organ transplant. You had the lungs and the liver. So can you sort of explain the circumstances of that patient and why that was necessary?
Yeah, so it's not the double lung in the liver that's novel in that case because that's been done for. It's the indication for it. So lung transplants have historically not been done for lung cancer.
Okay.
So if somebody has lung cancer that's not responsive to chemotherapy and radiation therapy, and there's nothing else you can do for them, they go to hospice and they die.
So what?
So in this scenario, we were saying we Northwestern's lung transplant program was the first to transplant lungs for lung cancer successfully. And so
Mhm.
now we've changed the indication for lung transplant. So now all these patients that are going to go to hospice and die have the opportunity to have a lung transplant. So to live.
Mhm.
Well, this particular patient was a physician himself, and he had lung cancer. And because of the chemotherapy and radiation, he developed lung scarring, but he also developed liver scarring. So he needed a liver transplant with a double lung transplant for the indication of lung cancer. So we flew him from California to Chicago, and we, through various different technological advances, so we, perfused the liver outside of the body with the machine, for example, to give us time when the lungs came out to put the new lungs in. And we put a new liver in. And this patient, who was a physician himself, instead of going to hospice and dying, got double lung liver transplant and is alive a year later now, cancer free.
Do you know why, like in the past, like lung transplants weren't used for patients with lung cancer?
Because people thought that anti-rejection medication that you give will cause the lung cancers to come back, and it was dogma at that time, and it was historically not been done above the diaphragm. Initially, we weren't doing liver transplants for liver cancer, but then we started to,
Mhm.
and many years ago, and we got good success from that. And now different types of cancers we're transplanting on the liver. No one had ever done that before above the diaphragm and lungs, and most of it was this idea because of around that cancer would come back with the anti-rejection medication. So we have to select these patients specifically that they don't have any spread outside of the lungs and things like that.
Mhm. All right. The last one, I think I know you didn't perform this procedure, but I heard that you did talk about it. So it's the pig heart transplant that you mentioned earlier. This one was like when I saw it, I was like, what? Because like you're taking like the organ of an animal and putting it into a patient. So can you like explain the science behind that? Like obviously
Yeah.
I think it's
So
right.
that's been thought of for decades too. People have started thinking about that since the 1970s. But new technology has allowed us to edit genes
Mhm.
within particular animals, most commonly pigs,
Mhm.
to edit their genes to take out genes that make them pig that would cause us to reject them, but also put in genes that make it look more human to keep us from rejecting them. And that's called the CRISPR-Cas9 technology. Okay. And so we were able to do that. We, meaning the field, we don't do that here, but our transplant field have been able to do that, specifically some industry backing, to grow these pigs that have more human-like organs. Um, so the science of this took a huge leap forward when they transplanted first human they first pig kidneys into humans that were brain dead, and it's in a model called decedent model, just as a proof of principle. And then in Boston, they transplanted a living human with a pig kidney. Now the problem is it did last, but only for a couple of months max. So it's not really ready for prime time yet because of we still haven't figured out some of the antibody mediated rejection portions of it, but did take a huge leap forward as some of those feats had not been done before, and that technology is really going to be part and parcel of the future of xenotransplantation.
With this, I was also wondering a little bit, because obviously with organ transplants, you need like a human donor, right? And I know there's like a lot of cultures or like personal beliefs that are sort of against donating organs. So sometimes like having organs available for transplants can be like an issue that comes in the field. But with the obviously with the animal heart transplants, like if that becomes like more reliable in the future that could be used. But I was also wondering, like, what are your thoughts on the ethics behind that? Like, yeah, because that could be a little bit hairy.
Yeah, so that's a big question. So no matter what, you're right about the cultural aspects of it, but even with the number of donors we have right now, we still don't have enough for the number of patients on the list. So about 130,000 patients on the list, and there's only about 8,000 donors out there every year. And every donor can donate 8 different organs or tissue types. Um, but it's not enough,
Mhm.
right? It's not enough, and there's a huge gap and disparity. Um, there is a lot of ethical considerations about growing animals for the pure purpose of um, saving human beings, right? Um, my personal opinion is that it's a huge leap forward in the science, and it allows us to um, bridge that gap better than we are doing right now. Um, I do think that it also is a potential bridge to artificial growth of organs, which we're not there yet for that, but this can potentially help in that. But I can certainly understand the other side of it, where people have animal rights activists and things like that that are ethically against it. So it's really a polarizing topic, to be honest.
Mhm. Do you see that do you see that becoming more common in the future, or do you think it's still going to take some time for that to be
I
more?
think it's still going to take some time because we have not cracked this antibody mediated rejection portion of it, which keeps the organ lasting for max 2 months, and we need to do better than that. So it's going to take some time still. We're not ready for prime time yet.
Right. Last topic, something I noticed in common with like a lot of your like the stuff you said for articles is that confidence is like a really important part of you being able to do all these like new transplants and stuff. So how do you stay so confident when you're doing things like the awake transplant that haven't really been done too much before? Is it just a product of like all the experience you've had over the years, or is it something else?
Well, I think it's experience, but it's also most importantly, it's this fundamental philosophy of being comfortable being uncomfortable.
Mhm.
And I think that one of the things I never want to do in my professional career is get comfortable. And I think the minute I get comfortable, I stop growing.
Mhm.
And I try to inculcate that philosophy within our entire group. So everybody's always thinking about innovation, moving the field forward, and doing what's right for patients.
Mhm.
Um, Whenever I always think about this, whenever Tom Brady throws a pass, even if it's a perfect pass, he thinks about how he could do it better.
Mhm.
And so even if we have great outcomes in a particular procedure, we should be thinking, how can we do it better? And then put ourselves in that uncomfortable situation to get comfortable with that so that we can put ourselves in another uncomfortable situation. So my philosophy is get comfortable with being uncomfortable.
Mhm.
That's I would call it more that than it is confidence, because the confidence are based on the principles of surgery and science that make it work. But it's the courage to be able to do it, which is the idea of being comfortable in uncomfortable situations.
Yeah. I think that's a great message, especially that's just how we keep pushing the needle forward, as you said.
Yeah,
All right. I think that's all we have for today.
great.
Do you have any closing thoughts you just want to add or no? Yeah.
No, I'm really excited that people are actually interested in this field of transplantation. It's my passion, and it's something that is really mind-boggling if you think about it. Like you started off by saying you take an organ out of somebody who's dead, put it in somebody who's living, and then save their life doing it. I mean, it's pretty amazing. And to think about it from your stage of a high school to my stage as a full-fledged faculty professor at Northwestern, and we both still have that same sense of awe for a field, is very unique for that field. And it's I'll say the same thing that my mentor said to me is never lose that sense of awe. And for any of your listeners, it is awesome and to never lose that sense of awe and to push yourself to be comfortable in those uncomfortable situations.
Mhm. All right. Thank you so much for your time. Have a great day.
You too. Take care. Bye bye.